So we're moving from controlled mechanical ventilation to assisted or spontaneous breathing. Because spontaneous breathing is certainly the best way to breathe, but I hope that I will show you some suggestions on how to understand when spontaneous breathing should be adapted or tailored to the individual patient. Because controlled mechanical ventilation might be dangerous, but in spontaneous breathing, the patient might damage himself. So we have to understand when to use what. First of all, spontaneous or assisted breathing means that the patient is making an effort, is working to breathe, more or less, but he is working to breathe. And why should we monitor the effort of the patient? First of all, because we might be willing to titrate the amount of support we want to give to the patient. Controlled mechanical ventilation means zero work of breathing. Spontaneous breathing means that the patient is doing 100%. If I select pressure support as an example, I am not defining anything, because it's better if I define how much of the work is made by the ventilator and how much of the work is done by the patient. Do I want the patient to work, to exercise? Do I want the patient to rest? Do I want the patient to work as much as he can without getting fatigued? How do I understand all these situations? Measuring the effort and the work might help me in recognizing failure or impending failure. We know that some patients fail assisted breathing, they cannot stand assisted breathing, and if we recognize that he is going to fail because through fatigue is much better for the patient. Perhaps we can adjust a few parameters so to adapt the ventilation, the level of assistance. Moreover, we know that ventilator-induced lung injury is not exactly ventilator-induced lung injury, it's ventilation-induced lung injury. We have animal models of ventilator-induced lung injury caused by spontaneous breathing. Because what is important in making the damage to the lung is transpulmonary pressure. And the young, strong subject might make a very high transpulmonary pressure himself in the effort to breathe. And so, because our end target is always to minimize ventilator-induced lung injury and ventilation-induced lung injury. This is an example of ventilator-induced lung injury by spontaneous breathing activity. This paper was published in 1999, exactly 1 year before the results of the ARMA study, the 6 versus 12 milliliters per kilo study were published. Actually, these are patients that were enrolled in that study. And as you know, in the US, the most common way of ventilating patients, at least at that time, I think it still is assist control. It means that the patient can trigger the ventilator. Now, when these patients were moved from 12 to 6 milliliters per kilo, they felt that they were not getting enough air. And so they were making inspiratory efforts. Inspiratory efforts means that they were trying to pull air from the ventilator, making negative intrathoracic pressures. The result is here in the title. Acute pulmonary edema, exacerbation of acute pulmonary edema. You know that the RDS is non-cardiogenic pulmonary edema, and if on top of that we apply negative intrathoracic pressure, that is strong inspiratory effort, the situation does not get better, it gets worse. And there are plenty of literature explaining how inspiratory efforts can cause lung damage. And the opposite of that is how beneficial can controlled mechanical ventilation and muscle paralysis be for severe ARDS patients at least during the first 48 hours. And our French friends showed that paralysis during the first 48 hours improves survival substantially. But it comes a time when we try to apply spontaneous breathing, because, as I said, spontaneous breathing has very good sides. I will not make you the list of the good sides of spontaneous breathing. We all here prefer to have spontaneous breathing than controlled mechanical ventilation, because the hemodynamics are better, the fluid balance is better, the muscle tone is better, we avoid atrophy of the respiratory muscles, and so on. However, we should keep an eye on transpulmonary pressure. This is controlled mechanical ventilation. We have 30 centimeters of water on the airways, 0, just to make a good number, 0 in the intrathoracic pressure. Transpulmonary pressure is 30 centimeters of water. Now, my patient is getting better. I try pressure support. I leave 30 centimeters of water on the airways. The patient is making -10. Now the transpulmonary pressure is 40 centimeters of water. And instead of decreasing the risk of ventilator-induced lung injury, I am increasing the risk of ventilator-induced lung injury. So if I want to maintain the same transpulmonary pressure, I indeed have to decrease the airway pressure. So negative intrathoracic pressure that you measure, as it has been explained to you earlier, negative intrathoracic pressure adds up to the airway pressure to increase the pressure, the transpulmonary pressure. It might even favor left heart acute insufficiency, as we will show. And if we have airway resistance, the situation is even more complicated. Now I am being protective. I really like very much my patient, and I have decreased the airway pressure to 20. The patient still makes -10. But I have a significant airway resistance. It means that at the start of inspiration, the pressure in the alveoli might be lower than the inspiration, because I'm trying to suck air inside the alveolus, but the resistance makes a pressure gradient between the airway and the inside, and we are used to think that elevated airway resistance is a problem of asthma or COPD, but it's not true. It's a problem of ARDS too. This is plotting airway resistance against end expiratory lung volume in normal, moderate, and severe ARDS. And you see that when the end expiratory, the more severe the ARDS, the smaller the baby lung. The smaller the lung, the higher the resistance. So you see that airway resistance might increase 4 to 5 times in ARDS. And the lower the level of support, the smaller is the alveolar pressure, and it might even become negative in average. This is plotting the alveolar pressure against the inspiratory flow, and you see that the higher the inspiratory flow, that is, the higher the drive of the patient, the lower the alveolar pressure. Why am I spending all this time in alveolar pressure? Because a negative alveolar pressure or a very low alveolar pressure causes a negative or a very low interstitial pressure. You know that water comes out from the vessels into the interstitium. The difference in pressure between the inside of the vessel and the interstitium is what drives the water out of the vessel. The higher the pressure and the lower the interstitial pressure, the higher the edema formation. And in a RDS, we even have another factor, that vessels are leaky, because a RDS is a microvascular disease characterized, between other things, by increased permeability. If I suck water out of the vessels, making negative pressures in the interstitium, the lung edema will increase, and the ARDS will get worse. What the patient does when he is in his bed in the surgical ward is try to breathe, making negative pressures with a leaky interstitium. At the end, we have a white lung. This is a famous paper by the group of François Lemaire in Paris and Warren Zeppel and Laurent Brochard, probably. I don't remember his position in this paper, but it's a very old paper. But it shows what happens to a patient going from being mechanically ventilated to spontaneous breathing. And when he's mechanically ventilated, the wedge pressure, the filling pressure of the left heart is here, something oscillating between 12 and 20 centimeters of water, millimeters of mercury, sorry. And we have a positive esophageal pressure. Then the patient starts breathing spontaneously. He makes huge negative intrathoracic pressures. You see how deep does the esophageal pressure go? And look at the filling pressure of the left heart. It raises up to 40, because negative intrathoracic pressure decompensates the left heart. And at the end, the patient gets into pulmonary edema. This is from a very important review paper from Norman Staub. Physiological principles are not expressed in journals anymore, because we all think we know lung physiology. But we should keep in mind that the generation of lung edema depends on two factors: the intravascular pressure and the extravascular pressure, plus the permeability of the vessels. And the pressure around the vessels follow very strictly the pressure in the alveoli. If we make negative alveolar pressures, then water will flow out of the vessels. And this is an example of a patient we thought was doing quite well. We put him on pressure support, and the lung did not get better. And we had to go back to control mechanical ventilation because, it's not that I needed the slide to show to you, it's that sometimes we make mistakes. And we did not interpret exactly the data coming from these patients. So how can we handle the monitoring of what is going on? Basically, we need to know how much the patient is working, and we need to know how high is the respiratory drive of the patient. Well, the gold standard, once again, is the esophageal pressure. This is a so-called Campbell plot. It's not very useful in the practical life, but it might be useful to understand it. This is the pressure volume curve of the chest wall. When volume increases, the pressure inside the chest increases. Below FRC, the pressure inside the chest is negative. This is the pressure, the lung elastic recoil pressure. And when the patient inspires, he makes a negative pressure around the lung, and the lung volume increases. Now, this looks very complicated, but if we rotate it in this way, and then again we have now volume in this axis and pressure in this axis, it gets more similar to what we see every day. This is the esophageal pressure. It goes down during inspiration. This is the esophageal pressure on the Campbell diagram that I have rotated. It goes down during inspiration. And this is the pressure volume curve of the chest, like the same I have here. Now, the difference between the pressure I should expect with a passive inflation of the chest and what I see is made by the patient. The difference between this point and this point is the pressure generated by the muscles of the patient, is exactly what the patient is doing. Again, this is the pressure in blue, the pressure generated by the muscles, and it causes flow inside the lung. Now, esophageal pressure is the gold standard. You see here a patient that can be weaned from the ventilator, and his esophageal pressure has a drop during inspiration, and at the end of the test, the drop has increased very much. What does it mean? He is struggling to breathe. At the end, he will fail. This is a success patient. The drop is much smaller, and moreover, it does not increase significantly in time. Had I seen and known this difference from the start, I would not have let the patient fail. I would have stopped earlier. Or I would have increased the support. Because I can adjust the amount of work the patient does and the amount of work the ventilator does. if I see that the patient is working too much, the simple solution is to increase the amount of work done by the ventilator. Here again, I have a patient in CPAP. He has huge drops during inspiration. I'm afraid he will fail. I'm afraid his lung will get white. So I go back to a higher level of pressure support, a significant level of pressure support, and now the drop is very much smaller, and the patient will not fail, will not get fatigued. However, esophageal pressure is indeed a gold standard, but it has a few problems. Not everybody uses esophageal pressures. We have, my friend Luciano asked you, how many of you use esophageal pressure? How many? 2, 3, 4? So we hope the use of esophageal pressure might expand, but still is rarely used. Can we do something to evaluate the patient effort without using the esophageal pressure? Well, we can use airway pressure-based methods, simply using what we see on the pressure transducer of the ventilator. The first one and the simplest one is PO1. PO1 is the drop in pressure in the airways during an occluded inspiration during the first 100 milliseconds of an occluded inspiration. The patient pulls from the ventilator against an occluded valve, and he does not know that the valve is closed. So he puts the force and the speed he thinks is necessary for his next breath. After 200 or 250 milliseconds, then he realizes that really the valve is occluded, and then he will react. But during the 100 milliseconds, he does not know. So if we measure the drop in pressure during the first 100 milliseconds, we can pretty well estimate the work of breathing. And we can estimate whether the patient is going to fail or not. You see, here we have patients with different levels of pressure support. The patient that increase substantially PO1 when we decrease pressure support are the ones that are not will stand a low level of pressure support that we call weaning failure. And a good PO1 is between 3 and 1, -3 and -1. A PO1 higher than 5 is a real problem. PO1 is not a difficult measurement. It's enough that you push a button on the ventilator, and all the ventilators will provide you with a PO1 measurement. How many of you did ever measure PO1? Substantial number, 4 or 5, good. Then we have the PMI, developed by my friend Giuseppe down there. Is a rather simple thing that you can do simply by pushing the end inspiratory occlusion button. When we ventilate our patient in pressure support, if he does an inspiratory effort, he makes a negative pressure around the lung. So the pressure that drives the tidal volume is the one on the airway plus this negative pressure generated by the patient. If we occlude the airways at end inspiration, at a certain point the patient relaxes. He understands that he cannot breathe anymore, so he relaxes. And now the chest relaxes and the pressure will increase exactly of the same amount of pressure that was developed by the muscles before. So this increase in pressure generated by end inspiratory occlusion is an estimate of how much pressure was the patient generating at end inspiration. Here you see a patient with a rather high level of pressure support compared with one with a lower level of pressure support, almost CPAP. And you see that the change in pressure at the end of this breath is very small, while it's much bigger during CPAP. Why? Because the contribution of the patient at end inspiration is much higher when the level of support is lower. And you don't need esophageal pressure to do that. You just need to push a button and read the pressure. A more sophisticated approach is using the diaphragmatic activity. The electromyography of the diaphragm is used to drive the ventilator to do NAVA, neurally adjusted ventilatory assist. You can get the electromyographic signal under any condition. And you can measure the electromyographic signal also during pressure support, as an example, or during CPAP. The electromyographic signal is proportional to the force, to the recruitment of the fibers of the muscles. And here we are talking about the diaphragm. So here you see CPAP, flow, airway pressure, the electromyographic signal, and the esophageal pressure. You see, they are specular. The electromyography goes up, and the esophageal pressure goes down. In pressure support, we increase the assist done by the ventilator, and the electromyographic signal goes down as well as the esophageal pressure. It means that if I monitor the electromyographic signal, be it during NAVA or during CPAP or during pressure support, I can get a pretty good idea of what the patient is doing with a nasogastric tube rather than with an esophageal balloon. Point is that we do not have a standard calibration of microvolts against centimeters of water. In one patient, 10 microvolts are 10 centimeters of water. In another patient, or at some other time, 10 microvolts are 5 centimeters of water. So we have to calibrate it, and we can calibrate it, once again, with an inspiratory occlusion. That is, we push the button of end expiration. The inspiratory valve will not open. The patient will pull from the ventilator, but the change in pressure in the airway, by definition, equals the change in pressure in the chest, because there is no change in volume. So now I can calibrate the electromyographic signal with the airway pressure, being sure that the change in the intrathoracic pressure is opposite, is the same as the change in the airway. And by doing that, we have been able to compute the pressure generated by the muscles simply by getting the electromyographic signal provided by the NAVA electrodes. Not during NAVA, or not only during NAVA, but also during pressure support or CPAP. In conclusion, monitoring the inspiratory efforts is essential in many cases. The esophageal pressure monitoring is the gold standard. PO1 is the simplest way of measuring the drive. PMI works most often in pressure support. The electromyographic signal is very promising. We are working on using the electromyographic signal of the intercostal muscles, that is with surface electrodes rather than with the nasogastric tube. And the results are very promising. I think I'm finished my time, and thank you very much.